Hi, welcome back to Chapter 2 content for the Psych of Aging course. After we've covered some of the physical aging topics in the first chapter, we move now into sensation and perception. Here we're going to talk about um, the five senses, essentially, and we're going to see that there are some age-related changes and adaptations that we want to talk about here. So let's start with vision. So first thing I want to do before defining and describing some of the actual age-related changes, I want to define a couple of terms here, at least this first one, low vision. It's a kind of common, reasonably common, I should say, experience with a decline in visual ability as we age. And I've just kind of described it in general terms here. So low vision is associated with a couple of things. One is kind of a loss of visual clarity, right? So there, we can talk about things being maybe a little bit blurry, or sometimes hazy is another kind of way of describing the experience. But also I want to emphasize the issue of a dimmer kind of visual experience. And there's a difference here between kind of blurriness versus dimming of the visual field. Blurry refers to clarity of detail, right? So if you need glasses, if you're nearsighted, for example, then when you're not wearing your glasses, things at a distance can be difficult to see clearly, but you still see lots of light, right? But you just don't have fine detail. But a dimming of your visual world means that something is preventing light from entering into your eye. So now there's less light making it to your eye, to your retina. And so overall, the world does not appear quite as bright and rich as it previously did, perhaps. And so both of these things happening lead to what we call low vision. It comes in degrees, right? So there can be very, very mild effects. But if it's in many cases, the cause of this can be something that is progressive. And so then a person's visual abilities just get progressively worse and worse and worse as this underlying cause maybe gets worse and worse and worse. Now, I'm defining this first because many of the things I want to talk about coming up here can all cause low vision, but for different reasons. And for the first thing here, we're going to start with secondary aging effects. So if you remember from the first chapter, I distinguished primary aging effects, which are age-related changes that are caused by age directly, versus secondary aging effects, which are changes that correlate with age, but they're really caused by something else, right? Some other kind of maybe disease process or condition, or in many of these cases from an accumulation of environmental exposure. So, for example, dry eyes, right? So dry eyes doesn't necessarily cause any particular visual impairment, though it can occasionally result in blurriness if you're having a little bit of trouble keeping your eyes moist and lubricated, and it kind of becomes, but it mainly becomes kind of uncomfortable and maybe even painful in certain cases. But it certainly can affect visual clarity here and there. Um, so it is a condition, of course, that affects older adults. It can be caused by various illnesses. There are known to be, for example, say autoimmune conditions. One example is called Sjogren's disorder, Sjogren's disease. And this is when the immune system attacks a lot of the mucous membranes of the body that produce various fluids. People have dry mouth, dry nose, dry eyes, right? So that's one example. Of course, that can happen to people across the lifespan, but sometimes autoimmune disorders like that progressively get worse as one ages. One obvious case is it can be simply a result of hydration issues, and so if you're not fully hydrated, that you're dry, and so of course you can have dry eyes from that. But environmental exposure, this can refer to it being in a dry climate, but it can also be the result of, say, exposure to pollutants. That can also affect the ability of the tear ducts in the eye to function properly. Related a little more closely to visual functioning and low vision, are some changes happening to both the cornea and the lens of your eye. So the outer layer of your eye is the cornea. That it plays an important role in collecting light and funneling and focusing it down into the pupil so that it can then pass through the pupil. Sitting behind the pupil of your eye is the lens, which does the final focusing of the light rays to create an image on your retina inside of the eye. So light has to pass through both the cornea and the lens before it makes it into the to the retina, right? So as people get older, we can have some coloration here happening to both the cornea and the lens, right? So they can they darken a little bit. And so here you can imagine this dimming of the visual experience because if there is some sort of darkening and coloration of these what would normally be fully transparent tissues, then some of that light doesn't make it through. So you can have some altered color perception, but also maybe just low vision because less light makes it into the eye. In many cases, this can be caused by, say, again, environmental exposure like pollution, or as I've described here, UV exposure. So in this case, just being in bright sunlight, all of that light, that's the UV stuff is damaging to our body tissues. And if our eyes are continuously exposed to a lot of UV, then we end up potentially with having some of these changes. But it takes a long time, right? So again, it's like a lifetime worth of being exposed to a lot of ultraviolet light, bright sunlight, without wearing, say, UV protective sunglasses or something like that. You can have these kinds of changes here. Glaucoma is another secondary aging effect here. This is caused by essentially hyperglycemia, right? So high blood sugar that comes from associated with diabetes. And if you're not managing your diabetes and you have chronic high blood sugar levels, this has, of course, a lot of health consequences. It can affect sensory nerves in general, so that people with advanced diabetes might have numbness and tingling in their fingers and toes. But in this case, we're looking at damage to the eye. So we're increasing um, intraocular pressure. I see that I have a typo on my slide. Sorry about that. I typed process instead of pressure. And what I'm talking about is the fluid inside of your eyeball that helps your eyes keep a full rounded shape. Of course, we want that, but if that starts to increase in pressure too much, it presses against the cells and the neurons of the eye, including the axons of the ganglion cells that form the optic nerve. And so here it can damage the optic nerve, and this can ultimately cause permanent damage to the optic nerve. And so again, it starts with kind of milder symptoms that are similar to low vision, and then it kind of progressively gets worse and worse as the disease, if the the diabetes progresses and the symptoms are not being managed well. This is not reversible, but it can be stopped, right? So as long as you are kind of managing the diabetes, and of course there are other kinds of treatments that kind of can assist in reducing the intraocular pressure of the eye, that can essentially halt the progression of glaucoma. But any damage that may have already been done so far, we don't have a way of reversing that. Uh, Now, I mentioned changes to the lens earlier, and so that's what we're talking about with cataracts here. So, um, separate from the brunescence that happens from UV exposure, cataracts cause a kind of a much more of a significant darkening of the lens and even more of a cloudiness in the lens, right? So, in this case, what's happening is the cloudiness is formed because of certain chemical and cellular changes and maybe even some cellular damage inside of the lens. And this produces quite a bit of a stronger low vision effect compared to anything else listed on this slide, except for, of course, very, very far advanced glaucoma. Um, so in this case, this can be caused by UV, like I mentioned. It can be caused by smoking and other pollutants that can damage the eye. Um, Curiously here, I listed steroid medication. So it's not necessarily a super common side effect, but if you're taking something like prednisone, a steroid that serves as an immunosuppressant, it can cause cataracts as a side effect. So in this case, we could call that a secondary aging effect because it might be slightly more likely that older adults may have to take that for various reasons. And it could be because of an autoimmune disorder and you use medication like prednisone to suppress the immune system. Could be that you just have maybe some kind of inflammation somewhere in the body. And so again, that can suppress the immune system. If you've had a if you've had an organ transplant, that's not necessarily what quite as common, but in a situation like that, to prevent rejection, you would use an immunosuppressant, and that can again cause the cataracts. But I also note here that cataracts can also be a primary aging effect. So while there certainly can be a variety of environmental causes or medical causes, it can also just naturally occur with age as well. And that's going to be something that just has some degree of individual differences. This can be treated reasonably well. Yeah, a lot of the eye surgeries that you can get involve lens replacement. So yes, in fact, when they do these surgeries, they insert an artificial lens into a person's eye, and it doesn't necessarily work exactly like a natural biological lens, but it works well enough that it is a very common way of treating cataracts now. I have some images here to help us visualize and understand what it's like to experience some of these effects here. So, uh, low vision here on the right. So again, there's some distortions and blurriness, right? So the distortions, sometimes we might call that things that are bent, right? So it should be a straight line, but it appears more wavy and bent. So the trophy that this boy is holding in his hand appears to kind of be bending in a weird way. And there's also some blurriness and haziness in the background as well. We also see just straight blurriness in the bottom left as well. But something else that I didn't mention very much is these dark spots forming in the center. So a lot of times what happens is that the nerve damage that is happening to the optic nerve that I described is affecting axons coming from the center region of your visual field more so than any of the other axons. And that's going to cause essentially this kind of blind spot right in the center of your visual field. So in that case, we see that kind of darkening in that one region as well. So a lot of that kind of stuff is happening with low vision. Here we see glaucoma on the top. We see the opposite happening. Um, so what's happening here is that you start to see it's kind of like tunnel vision, really, right? So as more peripheral effects are going to start um, kind of working their way in, kind of causing that darkening and blurriness in the edges. Late stage glaucoma, then you can only have central vision here. Here's a simulation of cataracts in the bottom left. So again, you see that it's certainly very, very blurry. But what's also we're looking at here is there sort of like a dimming a little bit. You can kind of tell where the colors are just not quite as bright and vibrant as they are on the left-hand side there. Now let's talk about primary aging effects a little bit more for vision. So something that happens to a lot of people. Um, it happens to me. I'm only 56, and yet I've been wearing my reading glasses for at least 10 years, I think. It's called presbyopia. So mentioning the lens again, but instead of talking about cataracts that cause the lens to get cloudy and not let light pass through the eye effectively or pass through into the eye effectively, here, what's going on is that the lens, being an actual piece of biological tissue, does continue to grow as we age, but it grows in this kind of asymmetrical way. And like any lens, like a lens in a camera or in a telescope or microscope, in order to focus near and far, you have to be able to adjust it, right? And when you adjust a lens, you have to change its thickness. Making it thicker is better for looking at close-up objects, and making it thinner is better for looking at faraway objects. And that's true of a telescope, but it's true of just in your eye. You look at something close up in front of you, and you're going to change the adaptive state of your lens. And then if you shift your vision to looking at something that's much further away, again, this changes the state of your lens. And there's a small muscle, circular muscle inside of your eye that controls the state of the lens. Well, what happens as the lens gets older, it gets a little bit kind of in this, it grows in this weird asymmetric shape, and it gets stiffer, and it's harder for it to take on the appropriate thicker shape for close-up viewing. And so this is called farsightedness. A lot of people who wear glasses like prescription lenses from childhood have the opposite condition. You're nearsighted, where everything close up is mostly in detail, but farther away stuff is a little blurry, and that's what your glasses help with. But this is the opposite. So farsightedness is when everything far away is in normal detail, but things that are up close are, in fact, quite blurry. And so it's not uncommon, for example, I got the Psych of Aging book right here. So it's not uncommon. Like, so for me right now, yeah, the text is quite blurry. I can kind of sort of read it, but holding it at arm's length, it becomes quite a bit easier to read. So you oftentimes will see older people holding things further away to help them read. And when that doesn't work anymore, that's when it's time to put on the reading glasses, which are just magnifiers. That's why you don't need a prescription for them. You can find them at any store. You just find the level of prescription that works best for how bad off your eyes are. So this is something that it doesn't necessarily happen to 100% of people, or maybe still a large percentage. But what can also happen is that the timing of this in terms of when it happens. Like I mentioned, this started for me in my mid 40s, but for many people it might not start until they're in their 50s or 60s, right? And I mentioned reading glasses as one solution to this, but for people who are already nearsighted and they use their regular prescription lenses for regular daily viewing, then what happens is that they become both nearsighted and farsighted as a result of this, or actually kind of everything is blurry. So this is where bifocals are also useful, because the bifocal has two different kind of lenses built into it. One is you look up to the top half of it for far away viewing, and then you could look down through the bottom half of it for reading and other close-up viewing. What else we have here? One other primary aging effect. I should emphasize this can sometimes be a secondary aging effect caused by various exposures, like smoking and poor diet, and high blood pressure associated with poor diet, like a high sodium diet, maybe UV exposure. But this also just commonly happens as an age-related change as well. It happens a little bit more in much older people, right? Unlike presbyopia, which can start in middle age and then gradually get worse. Age-related macular degeneration, or AMD, is something that you might only see in adults over 70 or even 80. So as I kind of showed with that the image previously of low vision, these kind of distorted and wavy regions of the visual field can start to happen. And again, blind spots in central vision, because as I was describing, some of this nerve damage that affects uh, the optic nerve is affecting regions that are more in the central part of your visual field. In fact, that's what the macula is, I should say. So the retina is the interior lining of your eye that contains the rods and cones, the photoreceptors, but in the center is a region that's more densely populated with cones, and that's called the macula. And then even in the center of the macula is called the fovea, which is the very dead center of your visual field. It's very densely packed with cones. And it's this more central region of the macula and the fovea that can start to become damaged as a result of this. There are two forms of AMD, dry AMD and wet AMD. What's going on with dry AMD is simply just that many of these cells begin to die, and as a result of this, we're going to start to see, just less photoreceptors, and so there's a decline in vision as a result of that. But the cells themselves, the dead neurons that are in there, they can't really be cleaned up very well. So the fragments of these tissues just sort of accumulate, and further causes further damage. And also the cells kind of release some waste products that also maybe causes further damage. And so you're going to have just a gradual progressive loss of central vision as a result of that. Wet AMD is caused by some abnormal vascular growth. So the veins, the arteries and the veins that feed into the eye to provide nourishment for all of the cells in the eye, sometimes these grow in overgrow, especially in some places where they're not supposed to be, and then they start to leak. And so they leak their contents and some blood and some other waste products into the retina, and this starts damaging cells in the retina. Sorry if you hear all this banging and so forth. They're putting a new roof on the Psych building, so we deal with some occasional banging during my attempt to record a lecture here. Um, so here is a depiction of both dry and wet MD in terms of what's happening in the retina. So on the left we have just a retinal image here. I mean, these are drawings, right? But they do a decent job of kind of capturing what the effects are. So you see, like I said before, you have your entire retina that we can see, and in the center we see these kind of nested pink dots, right? So the larger pink dot is the macula, that kind of overall broad central region. But as we move down further and further to the center, we get an even darker little region in the middle, and that's the fovea, where you have your greatest level of visual detail for seeing. The white dot off to the side, that is the optic disc. That's where the optic nerve leaves the eye. So there's a gap in your vision there. That's depicted a little bit overly large here, it seems to me. But you can also see the blood vessels also enter and exit the eye through the same place. So with dry AMD, this, kind of spottiness that occurs because of these kind of accumulation of waste products kind of here and there across the retina, but largely located in the center there all around the macula. Wet AMD, we're seeing here that darker splotchiness in there in the middle, and that's caused by, those blood vessels. They're bleeding out, and they are causing little microhemorrhages that are disrupting and damaging cells all throughout the center of your visual field there in the fovea. This is another depiction that kind of shows us what's going on with macular degeneration. So on the left is dry AMD, and you get these little patches, right? These little patches here and there that are a little bit blurry and faded. The wet AMD you see causes that stronger decline in central vision, right? That darkening right there in the center. Okay, let's shift over to hearing. Next up is presbycusis. One thing I didn't say about presbyopia, notice the same prefix here, presbyopia, presbycusis. Presby means effectively old, right? So presbyopia means old eyes, and it's referring to this very, very typical age-related change in lens function. Presbycusis means old ears, and it's a kind of a similar gradual age-related change in hearing. It's a primary aging effect. What happens is we have to think about the normal range of human hearing, right? So humans can normally hear frequencies as low as 20 hertz, which is a very, very low pitch, almost a rumble kind of a sound, as high as 20,000 hertz, which is a very, very super high pitched kind of a tone. And even over the age of 30, we start to lose some of that upper range of our hearing, like over 17 or 18,000 hertz might be gone even by the time you're 30 or 35 years old. And that loss of high frequency hearing just kind of progresses from there. So over 40 and over 50 and so forth, you start losing more and more of that upper range. And then at some point, it starts to just affect overall hearing, right? So it's just you have this overall reduction. This is a little bit more common by the time we get to people over 65 or so, that people are going to start having an overall reduction in just the loudness of everything, right, at all frequencies. And one of the most common effects here that people will report is they just have a hard time understanding other people when they're talking, right? Especially in a noisy environment, right? Just this reduction kind of makes it very much more difficult to understand speech in noisy environments. So speech intelligibility here becomes impacted quite a bit. So as I said, this is a primary aging effect, right? What's happening is that we have cells in our inner ear. They're called hair cells. They function kind of as the same job as the rods and cones in the eye, right? Rods and cones detect light and convert that into neural signals. Well, the hair cells of the inner ear detect the sound pressure waves of a sound producing event, um, and then they send that, you can turn that into a nerve signal. And so as we start to lose these hair cells, which can happen very gradually as a result of age, then that's going to start causing these effects. That's what we're seeing here. What's also can happen here, though, is called noise-induced hearing loss, which is a secondary aging effect, right? Because now this is what happens where, let's say sometimes it can happen because you're exposed to a really, really loud sound all at once, right? Like there's I don't know, an explosion or something right next to you that right in your ear and it causes damage and like just completely destroys your eardrum and damages some of the parts of your inner ear. But more likely and more common to happen, perhaps, is that someone might work maybe in an occupational setting that's very, very noisy. It could be a factory with lots of machinery. They might be a professional musician. Maybe they are um, around engines like large machinery, cars, race cars, airplanes. You work at an airport, right? And so if you're around these kinds of loud things, you're supposed to wear hearing protection. And of course, nowadays there are lots of rules and regulations that force people to wear hearing protection, and you get in trouble if you don't, or managers get in trouble if the employees are not wearing it. But if we go back 3 or 4 or more decades into the past, we see that that was not just well appreciated, how significant it is to be exposed to loud sounds like that over the course of your whole life, right? So you spend 20 years or 30 years or however many years exposed to those kinds of sounds and you're not protecting your hearing. What happens is you have minor damage to your ears with each exposure. And after many years of that, that minor damage accumulates to becoming much more of a significant and profound form of hearing loss. There's another term for this, by the way. It's called accumulative trauma disorder, and this is one example, at least, of accumulative trauma disorder. Anytime people in work environments perform repetitive movements a lot, there's risk of getting injuries that accumulate over time. That's what tennis elbow is, right? So elbow tendonitis happens because you're performing maybe a repetitive movement with your arm that's causing a little bit of strain on that tendon. And that strain and the pain that comes with it is something that maybe is brief and short-lived. It goes away with rest and recovery. But that strain was, in fact, a real injury to the tendon. And if you keep doing this again and again and again, eventually that pain doesn't go away and it becomes tendonitis, right? And then again, so that's called accumulative trauma disorder because the minor injuries that healed with time and rest and recovery stop doing that. They become permanent injuries. That's the case here with noise-induced hearing loss. One of the things we want to say about this here is that there is a common observation called the 4K notch. What this is referring to here is that if we give someone a hearing test, what we do is we present tones of varying loudnesses and we ask a person if they can hear it or not, right? So we want to know which ones they say, yes, I can hear it. But you also present tones of varying frequencies as well. You give them low pitch and medium and high pitch tones because what we find is that our hearing is not level across all of the frequencies. Even a person with completely normal and excellent hearing has greater sensitivity around 4,000 hertz. And that's important because if your ears are very, very sensitive to 4,000 hertz sounds, then if you are exposed to really loud sounds that also happen to be in that frequency range, which many common sounds are, um, then the that aspect of your hearing being the most sensitive is also then the most likely to be injured because it is very sensitive and then it can be damaged by that. So what happens then is that through the exposure to this noise, you kind of have this very selective loss right around 4,000 hertz. It can it can expand out a little bit, anywhere from 3,000 to 6,000 hertz technically, but very common. It's centered right around 4,000 hertz, and that's what audiologists refer to as the 4K notch. Because when you make a graph of someone's sensitivity to the sounds, you'll see this little blip right there in that frequency range, and that's a very strong tell about this being a form of noise-induced hearing loss, as opposed to just regular age-related hearing loss like presbycusis. It's also quite likely that noise-induced hearing loss will be accompanied by ringing in the ears, tinnitus or tinnitus, depending on how you want to say it. Um, Hearing aids, or how we treat all of these things, right? Hearing aids will simply just be small amplifiers. What's critical here is that we're not just boosting all of the sounds equally, but again, we want to target those sounds that are most impacted. So if you have a 4K notch, then mainly we just need to turn up the amplitude on sounds around 4,000 hertz, right? Although there is no particular cure for tinnitus, you might find various claims online about things that claim to improve or eliminate it, but none of them are particularly effective. All right, let's move into the sense of touch now. Somatosensation is what I want to call it. That means body sensation. So we are aware of what our bodies are doing. And so the sense of touch at the skin surface is just one small part of that. We also have proprioception, because what we have in our skin is we have mechanoreceptors, right? These respond to pressure. So any pressure and poking on the skin, or bending and deforming the skin when I touch something, activates these receptors through the mechanical activity on the skin. Um, but these receptors also respond to any mechanical stretching and pulling of the muscles and tendons. So we have separate receptors embedded in the muscles and tendons. And so when I move my arm around, that's also what's happening, right? I'm stretching the muscles, I'm stretching the tendons, and it activates receptors that are, again, these are mechanoreceptors. So what we see is that, just like with a gradual loss of receptors in the eye or the ear, we can lose some of these receptors in the skin and the muscles as well. And that means that we're going to have a gradual, slow accumulation of declines in our tactile perception, right? So here we're talking about just being able to perceive. I'll use my coffee mug as an example. Just as I move my fingers over this, and I uh, can feel the texture of it, uh, that kind of textural perception could be impaired, right? The ability to discriminate maybe the smoothness of one part versus the more rough part uh, is impaired, right? So we'll call that tactile acuity, the ability to detect fine surface structure details in an object that you can touch by hand. Sensitivity is just your ability to feel any stimulus at all. So if I apply a very, very faint touch stimulus to the skin, one question is, can you even feel that or not? And normally we're quite sensitive to even a very, very slight, even a hair touch across our skin, we can feel that. But in cases where that starts to decline, then maybe you can't feel that at all. Curiously here is that we have, as part of the touch perception system, we have what's called a nociceptive system, which is the pain processing system. So we have specialized pain receptors that follow their own specialized path up to the brain and get processed a little differently than regular touch perception does. And you might think, oh, well, isn't this doesn't sound so bad, because now, if I get a little cut on my hand, which happens, of course, um, it won't hurt as much, right? So that sounds like a good thing. Well, okay, maybe in some cases, but there are some problems here, because oftentimes what will happen is that you might cut yourself and you don't feel it because it's not so painful, and then maybe you don't attend to it promptly, and this maybe causes something else. Maybe you get an infection because you didn't notice that you had a cut. You didn't feel it. It wasn't painful. um, Another thing that can commonly happen with older adults is that they might touch a hot pan in the kitchen, and because of having reduced pain perception, they don't realize that it's a hot pan. It feels warm, but it doesn't feel like burning hot. So they touch it, they hold on to it for too long, and then only a few minutes later they discover they've burned themselves maybe quite badly, right? And so now they have a blister or something, and like they didn't realize it was so hot that it could cause a second degree burn. But now they do have a second degree burn, and now they have an injury. So there are some pretty obvious downsides to having reduced pain perception. It's adaptive to feel pain, of course, right? The decline in the proprioceptive stretch receptors of the muscles and tendons also has a downside, right? If we lose some sense of our body posture, can't feel my arms positioned quite as accurately as I used to, perhaps, then it might cause me to have some coordination issues, right? I can't control and move my body as effectively. I don't really know what's going on there. And here we could imagine fall risk as being another potential concern for something like this as well. Also related to fall risk is uh, some decline in our vestibular system. So this is we usually think of it as your sense of balance, right? These fluid-filled organs in your inner ear. And in this case, if you have any disruption of the activity of these cells, sometimes you can get dizzy, vertigo. Um, and and of course, then if you have dizziness or if you just have a reduced ability to detect your balance because of loss of cells in the vestibular organs, then again, fall risk becomes a much more serious concern here. I have a note there that it's comorbid with presbycusis. What do I mean there? Comorbid means it commonly co-occurs together. And in this case, the loss of hair cells in the inner ear, well, as it turns out, the vestibular organs are right next to the inner ear, and the kinds of neurons, the hair cells in the inner ear are also the exact same kinds of neurons that you find in the vestibular organs. So if you have a particular aging process that is resulting in the decline of auditory hair cells, it is very likely it's also going to lead to a decline of vestibular hair cells, and you might see the same kind of vestibular effects occurring in people who are already showing some profound age-related presbycusis. Finishing up the five senses, we have taste and smell, known as the chemical senses, because they respond to different kinds of chemicals in the foods that we eat. You might know about the five primary taste sensations of sweet, sour, salty, bitter, and savory, or umami, right? And so we have different kinds of taste bud receptors that respond to the different chemicals that come from, say, sugar compounds that taste sweet, or salt compounds that taste salty, or acidic foods that taste sour, and so forth, right? So one thing that happens is there can be a decline in salivation, just like talking about dry eye and less fluid production from the mucous membranes and the ducts that produce saliva. Saliva plays an important role in helping to dissolve food in our mouths, and those dissolved food particles then can work their way down into the creases of the bumps of your tongue, so that way you can get into the taste buds. And so reduced salivation has a direct effect on the ability of that to happen. So there's going to be some decline in taste perception as a result of that. But as we've been seeing here, we can just have a decline in these particular sensory neurons, right? The taste bud populations in the tongue might decline. In the nose, we have what's called the olfactory epithelium, and that's a layer of cells that are specialized chemical receptors in the nose. And losing both of these can affect not just taste and smell, but overall flavor perception. One thing we should emphasize here is that when you're eating something, it's very common to get what's called a retronasal effect, right? So while you have food in your mouth and you're chewing, molecules from that food are entering your sinus cavity through the tube in your back of your mouth, right, and through the throat. So that's retronasal, right, coming up into the nose backwards. This affects your ability to perceive flavors. If you ever have a stuffy nose and your sinus passages are blocked up, and then when you're eating, you kind of everything doesn't taste right, that's exactly the reason why. So taste and smell interact with each other. So we can see then that flavor perception can change, the enjoyment of food can change, of course. As we see here, sweet and salty taste are oftentimes more likely to be affected. And that's concerning because if the food that you would normally expect a certain amount of salt taste to be there and you add salt by an amount you're used to and it still doesn't taste right, which maybe makes you want to add more salt. And adding more salt to already salty food is not particularly healthy, especially for older adults who might need to worry about managing their blood pressure because higher sodium intake means higher blood pressure. So if you already have a blood pressure concern, congestive heart failure concern, or anything like that, and you have to have a low sodium diet, then this is going to make it kind of harder to deal with that. Of course, we don't necessarily want to add more sugar to our diet either. So maybe, if you have to add more sugar to your tea or coffee or just to things in general, everything tastes more bland. So you're trying to compensate for that in some respect. Now, as I know, there's a primary aging effect in many cases, but it's also worth noting that there can be many secondary causes of these changes. Smoking, again, can affect the population of these sensory neurons, both in the taste buds and the olfactory epithelium. Very well established by now is are the loss of taste and smell from COVID and long COVID. Though it's not the only virus that can cause this effect. So, lots of viruses can be linked to anosmia, is the loss of smell. It's also important that it's one of the early signs of Alzheimer's disease. That doesn't mean if you have anosmia, you're going to get Alzheimer's, but there is a correlation there that many people who are progressing in Alzheimer's will start to show anosmia. Of course, you do other additional tests to rule out any of these other possible reasons for not having a sense of smell. But the idea is that there are any number of other disease processes that can also cause these effects here. Okay, well, we have now successfully completed this chapter on sensation and perception.